Okay, let us start. You know, this is a multi-system disorders block, and multi-system disorders, we mean different systems are affected by a single disease. So although a disease may be primarily linked to a certain organ or system, it may affect the other systems as well. And one of the most striking features, or one of the most striking parts of this, can be seen in hematology. Many disorders are reflected in the blood. You know, complete blood count is the first lab investigation that you should perform for almost all diseases, regardless if it is an internal disease or a pediatric or a surgical disorder or whatever, because it gives very valuable information about the patient, about the well-being of the patient. They're like the complete blood count is like the vital signs, such as, for example, you measure the blood pressure, the heart rate, respiratory rate, fever, and then first thing you should look is the complete blood count. Does he have anemia? What about the platelet count? What about the lymphocyte, leukocyte count, etc.? So, and also, peripheral blood smear, as I have emphasized many times in previous lectures in the hematology block, should not be overseen. Peripheral blood smear also gives you very valuable information. So the most of the diseases that are associated with hematological manifestations are usually infections, acute and chronic infections, connective tissue disorders. Also, neoplastic diseases have many hematological manifestations, as well as storage diseases, which you had some lectures about storage diseases. You have already seen these. What are the mechanisms of those hematological manifestations? They may be due to bone marrow dysfunction, resulting in anemia or polycythemia. They may result in leukopenia or leukocytosis in some cases, or thrombocytopenia or thrombocytosis. So either increase or decrease in the number of red cells. Also, you may see changes in the hemostatic parameters, such as acquired inhibitors to coagulation factors, acquired von Willebrand's disease, platelet dysfunctions, and changes in the factor levels in different diseases. One of the most important things that you should learn in this lecture is anemia of chronic disease or anemia of inflammation. This is associated with a vast number of acute and chronic disorders, such as infections, as the name implies, collagen vascular diseases, connective tissue disorders, renal disorders, neoplastic disorders, and severe tissue injuries. Usually they have mild to moderate anemia, not very severe anemia, mild to moderate anemia, and usually it is normochromic, normocytic anemia. In some cases, you may have microcytic anemia as well. You may see mild anisocytosis with showing as increased RDW, red cell distribution, within those patients. So the basic underlying pathophysiologic mechanism is insufficient iron availability for erythropoiesis. I will explain the mechanism in more detail, but the basic mechanism is that although there is sufficient amount of iron in the body, that iron is not available for erythropoiesis. This is the main feature of this disorder. So In anemia of iron, the anemia of inflammation, usually serum iron and transferrin levels are low. Ferritin levels are usually increased, normal or increased, unless it is accompanied by iron deficiency anemia, of course. Serum transferrin receptor levels are normal, unless iron deficiency accompanies. And inflammation is the initiating factor for all these. And in the bone marrow, you can see iron deposits in macrophages, and this can be seen by special stain, Prussian blue stain. Coming to pathogenesis, there is an ineffective iron recycling, where erythroblasts, in this case, do not mature properly. And those erythroblasts are engulfed by macrophages in the reticular endothelial system organs, liver, spleen, and bone marrow. Normally, when they are engulfed, when they are phagocytosed, they degrade the protein and lipid, and they're in iron recycled to be used for hemoglobin synthesis further. However, in this case, this cycle is disturbed. Iron cannot be used. It is trapped in the reticular endothelial system macrophages, which can be seen in the Prussian blue staining in the macrophages. So this is one of the basic mechanisms. So what happens? Erythropoietin levels are low, and direct effects of inflammatory cytokines on erythropoiesis decreases the response to erythropoietin. So some cytokines are released, and these inhibit erythropoietin synthesis, erythropoietin secretion, and erythropoiesis in turn is affected. In addition to that, hepcidin is secreted by the inflammatory cytokines, and they also increase hepcidin expression, and this gives rise to decrease in intestinal iron absorption and decreased iron levels. So induction of hepcidin in response to inflammation results in most but not all of the characteristic features of anemia of inflammation. So to summarize all, in chronic disease such as infections, autoimmune conditions, whatever, there are some pathways. So the inflammatory cytokines, primarily interleukin 1, 6, and TNF-alpha, are released, and this release inhibits erythropoietin production from kidneys, so erythropoiesis is suppressed. Also, as a result of this, bone marrow response to erythropoietin is decreased. What happened? Interleukin 6 stimulates liver to produce hepcidin, and hepcidin inhibits iron transporter proteins on macrophages, and so there is decreased release of iron from macrophage stores and decreased absorption of iron from the gut. So as a result, heme synthesis or hemoglobin synthesis or erythropoiesis is decreased. However, despite all these, there is sufficient amount of iron in the body, but iron is not utilized. So the remaining iron is sufficient for the remaining red cells in the blood, which results in a normocytic anemia, not a microcytic or hypomacrocytic anemia. It's a normocytic, normochronic anemia. Here is a more detailed representation. Inflammation activates release of cytokines, IL-6, IL-1 beta, interferon gamma, TNF-alpha. They inhibit erythropoietin release, which gives rise to decrease in erythropoietic stimulation. Also, these increase hepatic synthesis of hepcidin. Hepcidin inhibits iron absorption, inhibits iron release from reticular endothelial system, all gives rise to normochromic, normocytic anemia. So what are the lab features? Compared with the iron deficiency, this is important. In both iron deficiency and anemia of chronic disease, iron levels are reduced. But transferrin levels, although it is increased in iron deficiency anemia, it is reduced or normal in anemia of chronic disease. Transferrin saturation is reduced in both cases. Ferritin is very much reduced, low in iron deficiency anemia, but in anemia of chronic disease it is normal or increased. So this is what I'm saying from the beginning. Iron stores are not depleted. We have sufficient amount of iron, but this iron cannot be utilized for erythropoiesis. This is, in a way, a protective mechanism against bacterial or infection, because the microorganisms require iron for growth, and so suppressing iron levels, decreasing iron levels, gives a protectory level protection against infections for those patients. Yes?
Doctor, for anemia of chronic disease, instead of like with other anemias giving iron supplementation, because that wouldn't help, do they give glucocorticoids or immunosuppressants?
Sorry?
For anemia of chronic disease, would they prefer giving glucocorticoids or immunosuppressants instead of iron?
Nothing is needed. The only thing you need to give is treat the infection, underlying disorder. No iron or nothing else is needed.
But if the underlying disorder, for example, is a neoplastic process or renal
Okay, if there's neoplastic disease or collagen vascular disease, of course you have to give steroids or whatever is needed. So treat the underlying disorder.
Yes.
No need to give iron or any other.
This iron supplementation would go into ferritin stores, right?
Ferritin is not reduced. Ferritin is even higher than normal.
So any iron supplementation that the clinician
It's not needed.
would go into ferritin stores?
Yeah,
right?
no need.
No
No need.
benefit.
No need. It may even be harmful for the patient.
Thank you, doctor.
And also, as I pointed out, cytokine levels are increased in anemia of chronic disease, whereas they are normal in iron deficiency anemia. So we're coming to certain diseases where we can discuss what the features of hematological values are in those disorders. I will give you some disorders, some examples. Okay? For example, one of these is collagen diseases and SLE. So, you know, anemia, leukopenia, thrombocytopenia are one of the common features of systemic lupus erythematosus. Okay? So, all are due to immune stimulation and the presence of antibodies, autoimmune hemolytic anemia with warm antibodies. Leukopenia, due to IgG or IgM type anti-lymphocyte antibodies. Thrombocytopenia, again due to immune sensitization, and which is the most common immune-mediated hematological manifestation in SLE. Also, in systemic lupus erythematosus, lupus anticoagulant and antiphospholipid syndrome, which is also associated with antibodies, is one of the common features in this disease, and which may result in thrombosis and miscarriages and spontaneous abortions. Juvenile idiopathic arthritis, this is also associated with anemia. It is a typical feature, typical type of anemia of chronic disease. But in some cases, you may see iron deficiency anemia due to blood loss through the intestine. Leukocytosis and neutrophilia may be common in flare-ups, and secondary thrombocytosis also may happen in those cases. In connective tissue disorders in general, bleeding and bruising is common because in connective tissue disorders, the vascular structure, the skin, subcutaneous tissue have increased fragility. So they may have easily bruised. Also, in those patients, you may have platelet aggregation abnormalities, but generally, they are normal. Clotting factors are normal. In some cases, you may have some problems, but in general, platelet aggregation factor levels are normal in those cases. When you have coagulation defects, you should suspect certain disorders such as Ehlers-Danlos or Marfan syndrome. So you should look at the patient, you should examine the patient as a whole. This is what I'm always telling. See that don't look at the patient as a single organ or system. You should examine the patient, you should perceive the holistic view as a whole, not as an organ or a system, but as a human, as a whole, as an organism. Infectious diseases are, in many cases, they have hematological manifestations. Of course, anemia of chronic disease is common, as the name implies, in almost all infections. Even in acute infections, you may have anemias. Usually there's a drop in hemoglobin levels in acute infections in the first week, which then increases during the resolution. And this is due to increased levels of hepcidin. And this is, as I have pointed out, is a protective mechanism against microorganisms. You may have transient bone marrow aplasia or selective erythroid aplasia, especially in some viral infections such as parvovirus infections, which may give rise to aplastic crisis in certain hemolytic anemia patients, such as hereditary spherocytosis, for example. Hemolytic anemias can also be seen during certain infections, which I have listed here, such as Clostridia, sepsis related to bacterial infections, certain congenital and viral infections. Also, autoimmune hemolytic anemia due to cold antibodies can be seen, especially mycoplasma infections and listeria infections. So when you have these type of diseases, patients, you should look for cold type antibodies. You should definitely look for the nature of the anemia in those patients. Coming to white blood cell disorders, you may have leukopenia or leukocytosis in viral and in bacterial infections. Usually viral infections are associated with leukopenia. These are the most common infections associated with neutropenia. But bacterial infections are usually, as you know, associated with neutrophilia or leukocytosis. Also, you should keep in mind that although most viral diseases present with leukopenia, they may at first manifest themselves with neutrophilia or leukocytosis in the first days of the infection. Morphologic changes, so the peripheral blood smear investigation is important. Looking for the peripheral blood smear examination is important. Döhle bodies, which are pale blue Christis-like inclusion bodies, can be seen in certain bacterial infections. So these are how Döhle bodies are seen, pale blue inclusion bodies. Toxic granulation is one of the most important features, especially in bacterial infections. You may commonly see toxic granulation in the neutrophils. Similarly, toxic vacuolation, you may see large vacuoles in neutrophils in the cells. Also, you may have pseudo-Pelger-Huet anomaly in certain cases. So you should definitely look for the peripheral blood smear yourself and see if the patient has any of these abnormalities. Okay. Again, lymphocytosis, lymphopenia are common features in infectious diseases, and these are the infections most commonly associated with those. Eosinophilia is mostly seen in parasitic infections. So when you encounter a patient with eosinophilia, which is more than 5% of the total leukocyte count, you should suspect those parasitic infections, Trichinella, Echinococcus, tapeworms, schistosoma, enterobius, etc. Also, it may be due to allergic sensitization to mites and in certain fungal infections, especially aspergillosis. Monocytosis is not very common, but can be seen in certain infections such as tuberculosis, syphilis, and subacute bacterial endocarditis. Basophilia is rarely seen, but still it may be reported in certain cases of tuberculosis, influenza, and sometimes in hookworm infections, but not very common, as I told you. To give you an example, when you look at the lab findings of infectious mononucleosis, here you see that most of the lab findings are hematological manifestations. Lymphocytosis, almost in all patients. Atypical lymphocytes, leukocytosis, neutropenia, bone marrow granulomas, thrombocytopenia, leukopenia. So you see, most of the features in such an important infectious disease are hematological findings. Clotting abnormalities and thrombocytopenia, DIC, disseminated intravascular coagulation or consumption coagulopathy, is very common. Well, common in some cases, of course, not very, very common, but can be seen, should be kept in mind, especially in some infections, certain in sepsis, meningococcal infections, Pseudomonas infections, Klebsiella infections. In sepsis patients, even in some viral infections, it should be kept in mind and should be treated accordingly. Thrombocytopenia can be seen in a number of different infections. Mostly infectious mononucleosis, cytomegalovirus, some bacteremia patients, congenital viral infections. Thrombocytosis may also be seen, especially in the active phases of some infectious processes. Bone marrow abnormalities and infections. Well, in certain infectious diseases, such as histoplasmosis, tuberculosis, Kala-Azar, salmonella infections, candida, they have been identified in bone marrow macrophages. Bone marrow granulomas may be seen, and histoplasmosis, tuberculosis, brucellosis, salmonella can be cultured from bone marrow aspirates. So these bacteria, these microorganisms, can be residing in the bone marrow cells. Of course, bone marrow infiltration is important both in neoplastic and non-neoplastic disorders. So when you see a patient with anemia, and when you suspect it may be due to bone marrow suppression, it may be due to neoplastic disorders such as leukemia or other malignant disorders, or non-neoplastic disorders, especially storage diseases. I will not go into detail for this. To give you a different example, I'm trying to give you different examples from different organ systems. Heart diseases may also be associated with some hematological manifestations, especially if the patient has prosthetic heart valves, or if the patient had surgery, especially for certain congenital heart defects such as ventricular septal defects, PDA. So they may have hemolysis due to mechanical injury, which may be seen as hemoglobinemia, hemoglobinuria, and in certain cases iron deficiency anemia as well. In infants with cyanotic congenital heart disease, you see, and you can see polycythemia due to erythropoietin induction. So they may need higher iron requirements because of the higher hemoglobin mass. And again, these patients may have mild macrocytosis. Again, in some congenital heart diseases, coagulopathy may be accompanying the disorder, such as thrombocytopenia, low fibrinogen levels, clot retraction, deformation, hyperproteinemia, low levels of certain factors. Acquired von Willebrand's disease can be seen in some children with congenital heart disease, such as aortic stenosis, ventricular assist devices, etc. Anemia and renal diseases. Renal diseases are especially chronic renal diseases, are commonly associated with anemia. They are usually due to deficiency in the erythropoietin production. Hyperproliferative anemia, usually normochronic normocytic anemia. Again, it is in the nature, it is in the type of anemia of chronic infection, chronic inflammation. So inadequate dialysis and secondary hyperparathyroidism may aggravate the anemia in those patients. Also, hematopoiesis may be suppressed by some serum inhibitors. So most patients with renal disease have shortened red cell survival due to a number of factors. When you examine the peripheral blood smear, yes?
Sorry, how would secondary hyperparathyroidism result in further reduction, further anemia?
Secondary
Increased PTH, so there's more calcium in the serum. How would that cause further?
Well, I don't know the exact mechanism. I will not search for it.
Okay. Thank you.
But this is what it is written in many textbooks, so I will search for it.
Okay, thank you.
Okay. So burst cells and red cell fragmentation is common, can be seen in most renal failure patients. Also, megaloblastic bone marrow can be seen in chronic renal failure patients, which may be due to folate deficiency caused by poor dietary intake, also due to hemodialysis or peritoneal dialysis. Or it may also be due to the use of immunosuppressive drugs used for those patients. Although we have anemia in most renal patients, if the patient has renal tumor, so release of erythropoietin directly from renal tumor cells may give rise to polycythemia in some cases. So you may be surprised the patient has renal failure or renal disease but have polycythemia. This is the mechanism. Again, granulocytopenia, neutropenia can be associated with renal failure patients. In many uremic patients, chronic renal failure patients, you may have mild to moderate depressed low levels of certain coagulation factor levels. In nephrotic syndrome, hypercoagulability and thromboembolic complications are common. It should be always kept in mind when you follow a nephrotic syndrome patients. So these are usually due to increased levels of certain factors such as fibrinogen, factor 8, and factor 710 complex. Platelet abnormalities, mild thrombocytopenia can be seen both in acute and chronic renal failure patients due to impaired production of the platelets. Also, some platelet function disorders in adhesion and aggregation can be seen, and these can be associated with clinical bleeding episodes, which can fortunately be successfully treated with DDAVP, desmopressin. Also, of course, long-term use of recombinant erythropoietin also reverses these findings. So, in summary, hematological manifestations, hematological investigations gives very valuable information for the underlying disorder and also gives clue for the underlying disorder, what the patient really has. Welcome. We have finished. You may leave. It may guide treatment and follow-up in many cases. Hematological findings, keep in mind, when you see a hematological finding, they are not always due to a primarily hematological disorder. You should search for an underlying disorder. And again, a holistic approach is necessary. You should not look at the patient as a single organ or system. You should see the patient as a whole and consider the patient as a whole, as a single organism. And you should keep in mind that no organ or system works in isolation. You cannot separate heart from the lung, from the blood. All work in harmony all together. Do you have any questions?
Sorry, doctor, if you don't mind, for the exam, how are we supposed, what kind of questions should we expect and how should we be studying for the section, for exam presentation?
You are experienced students.
No, it's a new block.
What do you mean, how should we study? You know how to study. You have come up to this stage.
Yes. It's because normally we take every single one of these points you mentioned, every single one of these diseases or infections, and then we study, okay, they can cause thrombocytopenia, whatever, separately. You know what I mean? So it's harder to mentally compartmentalize these things with their main effect as the focus. You know what I mean? It's like a reorganization of thinking. So I just want to know what kind of questions should we target ourselves with.
I know my question, I don't know the other faculty members' questions.
But for this lecture, specifically, you must like the exam.
I am not going to ask details,
Okay.
okay?
Thank
I have a
you.
question.
But don't come to me, oh, this is the detail you have asked. Don't come to me with this.
Okay.
I have a question regarding the chronic disease.
Sorry?
I have a question regarding the chronic diseases. You mentioned that the iron stores or iron cannot be utilized because of hepcidin. So if iron cannot be mobilized into the erythropoiesis pathway, why do we still see normocytic and chromophore when usually when hemoglobin cannot be synthesized, we see microcytic hemoglobin?
The new cells, new erythropoiesis is suppressed. Okay? So when you have iron deficiency anemia, there is insufficient iron. So the new red cells that are produced have small amounts of iron. But in this case, the existing red cells have sufficient amount of iron.
Even without the macrophages being able to release it, they can still.
The existing cells contain their iron until they are depleted. Any other questions?